Good evening, everyone, and welcome to the Orthopaedic Reconstruction Review course. We'll start in a few minutes just for all the people to join. I appreciate it may be late in different countries, but yeah, unfortunately, I have commitment on Friday. That's why it has to be late. Welcome to all of you, and today will be lecture number 1, and we'll speak broadly about biomechanics and of the joint replacement of the hip and knee. So could you hear me? Hatim, can you hear me? Perfect. Okay. And you can see my screen, do you? Perfect. Okay. So we will crack on just to be on time. So again, good evening, everyone. So today we'll speak broadly about the biomechanics and the basics of joint replacement of hip and knee. It's a very important lecture because you need to understand the key concepts and how you clinically apply these key concepts when you're doing your hip or knee replacement. We are not here today to speak about basic points. Basic points you found it in any source, but to make every and each point easy, understandable, and quite relative to your day-to-day practice. So my name is Mohammed Hashim. I'm a consultant Roman Orthopaedics in Northwest London, Friendly Health NHS Trust in UK, and I'm running the Ortho Excel educational platform. It's an absolutely free platform offering educational activities to orthopedic surgeons at different levels from different countries, and it's absolutely free. This is where I come from. So this is Heatherwood Hospital, where our elective hub, where we do all our arthroplasty cases. My relation with arthroplasty is a bit long. So to me, arthroplasty is the engineering part of orthopedics, and that's why I choose orthopedics as a subspecialty. It has a lot of mechanics, had a lot of understanding. You don't need to remember anything. You need to understand what mechanics, how your joint, the normal joint is working, how to replicate the normal working joint with your replacement. So this is the website for Ortho Excel, where all the educational activities will be announced, and this is the email if you want to contact me for any clarification about any of the activities. I have the educational YouTube channel, which have all the videos on, and this video, the record of this session, will be on this educational platform. Okay, so let's crack on and speak firstly about hip as a joint. So what do you need to understand from the hip biomechanics point of view? You need to understand that the hip is a multi-axial ball and socket joint. So ball and socket is a configuration of the joint. As you can see, there is a ball and a socket, which the ball is relaxing inside the socket, and this gives the hip a special stability rather than any other joint. So with this conformation between the hip head and socket, the bony configuration itself is one of the main factors which makes the hip is a very stable joint. You need to remember that the hip is taking, both hips are taking all your weight, and when you are single standing on one leg, this leg is taking about 5 of 6 of your weight. Muscles and ligaments around the hip is mainly to maintain the stability of your upper body, maintain the pelvis, balance it over the hips, and so the upper part of the body is balanced over the legs when you are walking during a stance or during the gait. It's critically to have a normal hip for you to do the normal daily activities and to get all the forces encountered during the daily activities supported and balanced around the hip. So how much this hip takes weight? So if you understand the idea of free body diagram, so this is your hip, your body weight is coming across here, and from the other side, so if we leave the body, if the body weight is working alone, it will pull the pelvis to this way, and so the pelvis will not be balanced. For the pelvis to get balanced around the hip, you have to have the abductors working on the other side, and actually not pulling the hip towards the pelvis, but pulling the pelvis toward the hip. So the body weight is exerting stresses along this line of action, and the abductors is tensioning and doing stress from the other part in the same line. This is going in clockwise direction, and this is going in anti-clockwise direction. That's why when you stand either leg stance or you're walking, your pelvis is maintained in equilibrium. And you need to have these forces equaled for your pelvis to maintain your pelvis stable over your hip. And so you can get your hip to do all the function you're waiting from the hip to do it. Okay, so from this understanding, you understand that as you can see, the lever arm between the body weight and the hip is about 3 times the lever arm between the abductors and the center of rotation of the hip. So actually the abductors is exerting about 3 forces of the body weight to maintain your pelvis stable over the hip. And add the resultant force from that is 1 force from the body weight in 3 times the lever arm on the abductor. So the abductor is exerting 3 times the forces the body weight is exerting. So in total, about 4 times your body weight is exerted in this direction over your hip. And there is an anti force, which is a ground reaction force coming from the ground rather than your foot will sink inside the ground. So forces around the hip is coming from the body weight itself with this long lever arm, and abductor tension or abductor action maintaining the pelvis in balance over this short lever arm is exerting more force. The 2 forces are in equilibrium because the abductor is exerting 3 times the force of the body weight to maintain the difference between them in the lever arm. But at the end of the day, both of them are exerting about the same force over the hip, and there is a counteracting ground reaction force maintaining this hip in place. So actually, when you're walking, the hip is taking about 2.3 to 5.5 times your body weight, and in a common average, taking about 3 times your body weight. While if you're jogging or running, if you're jogging or running like a fast walking, the hip is taking about 7 times your body weight. This gives you an idea how much the hip is important, how much the balance and maintain the mechanics of the hip is very important for you to do the normal activities, and how much is very important if you're doing a total hip replacement to affect the hip replacement longevity and stability. So understanding this, you understand how much forces are running around the hip from the body weight, from the abductors, keeping the pelvis in balance. This is the cornerstone of the whole lecture, about the whole part of the lecture around the hip. Because if you understand that well, you'll be understanding how can we balance the total hip. You understand how can we reduce the stresses over the total hip. How can we get the total hip to function for a longer time. So this is in diagrammatic shape. So the free body diagram of the hip joint, we understand that this is the center of rotation of the hip at the center of the head in a normal native hip. So the forces acting on it in clockwise direction is the body weight at lever arm, which is like A, and the forces of the abductors maintaining the pelvis in place and not allowing the pelvis to flip on the other side when you are on a single stance, working with this lever arm B. So body weight by A equal the forces of the abductors by B, and both of them are in equilibrium. And as you see the difference between the lever arm, that's why the forces the abductor is exerting nearly 3 times the body weight, which in a single link stance is about 5 or 6 of your body weight. This is the explanation of this. So if we give it a number like in a normal 70 kg body weight individual, so this will be nearly 60, and when it's normally 60, and this exerting 3 times this body weight. So this is exerting about 3 times of the 60, which is 180. So 180 and 60, this ending by you exerting a force of about 4 times the 5/6 of your body weight. So if you make it here, as you see, if you're saying that 60 kg weight, if we multiply this your body weight by the gravity, so it gives you about 600 Newton, which is the forces coming from the body weight. And if we, as we agreed, that this is about 3 times the lever arm A is 3 times B, so means you're putting weight of about on arm B, this is what you're putting about 1,500 Newton. So 600 Newton, 1,500 Newton in total, about 2,200 Newton going across your hip, and the body and the ground reaction force are the same in magnitude but opposite in direction. So your hip is under the forces coming from the body weight and abductors and the ground reaction force. So what is joint reaction force? So the joint, we need to be very clear the difference between ground reaction force and joint reaction force. So the ground reaction force is the forces the ground reacted against the weight you are putting, or the forces you are putting through your weight. But the joint reaction force is actually the joints, the compressive forces which is going across your joint. And when we speak about hip, we speak about the femoroacetabular articulation. So as we agreed again, so there is forces coming from the body weight and forces coming from the abductors, and we agreed that the abductor is doing the three times the job the body weight is doing. So mainly forces coming from the muscle forces, then and similar or a smaller amount of body of weight. I'm sorry, of stresses coming from the body weight. It has a special relation. You can put it in this triangle, which every arrow of it, the length of the arrow is giving you the magnitude of the force, and direction of the arrow is showing you the direction of the force. So body weight is represented by this small arrow, and the forces of the abductors is represented by this arrow. So the resultant joint reaction force is this arrow. And as I told you, the length is giving you the magnitude of the joint reaction force, and the direction is showing you the direction of the joint reaction force, which is represented by this arrow. So what's the clinical significance of that? This joint reaction force is the actual forces where the normal joint is facing. So when I put a total hip replacement, I need to be understanding how much joint reaction force will go through my total hip, because this will give me an idea how much this total hip will withstand before it fails. So give me an idea how can I maintain the longevity of my total hip. So you understand that if we reduce the abductor force, if we reduce the body weight, so we'll be reducing the resultant total force, which is the joint reaction force, and this consequently will reduce the joint reaction force, reduce the force going through your total hip. So give your total hip a more chance to be long waiting or long living. So in case of osteoarthritis, what happens? The articular cartilage is gone. There is more friction forces going through the hip. So these forces is magnified by the friction going across the hip. So your abductors needs more force to maintain the job. So the total joint reaction force will be increasing. So if you understand the joint reaction force, you'll be understanding how this will be affected in the osteoarthritis and how this will be affecting the total hip. So again, I'm reinforcing on this point because this is the most important point. So any hip have a body weight coming across here with a lever arm, then you have abductor force coming with a lever arm. These two forces are unequal. That's why the abductor force is exerting more forces to maintain the stability of the pelvis based on the longer lever arm of the body weight compared to the lever arm of the abductors. Both of them together is exerting a resultant force, what we call the joint reaction force. And this joint reaction force is the actual force going across your joint. And this is what shows you how much force will go through your total hip. And this where you have to play to maintain your total hip at exposed to the lower stresses you can, or the lower forces you can, so maintain the longevity of your total hip. So if I want to reduce the joint reaction force, the options I have to that is physiological and surgical option. Physiological option, firstly, to decrease the load, so decrease the body weight. In a simple way, if you reduce your weight or you lose some weight, you will be reducing this force, and as a result, you will be reducing the whole joint reaction force. The second option is either I move this body weight toward the center of rotation of the hip, which is not possible except surgically, or I move the lever arm of the abductors to do that. So how can I decrease the lever arm? This you do normally or physiologically in the Trendelenburg gait. So with the Trendelenburg gait, what you do, you basically lean toward this side. So you reduce the lever arm of the body weight. So you reduce the forces coming from the body weight by the lever arm. In consequence, the forces coming from the abductors to make the pelvis in equilibrium will be less. So the resultant force will be less. So the first physiological way is to reduce your weight. Reducing the weight will reduce the whole total force coming from the weight multiplied by the lever arm. In consequence, the equilibrium force will be reduced and the resultant force will be reduced. Second option is to do a Trendelenburg gait. If you see a patient with osteoarthritis or patient with weak abductors or patient with any reason, like patient with myelopathy, patient with any problem with the muscle, which the patient needs either to reduce the joint reaction force or to reduce the forces needed from the abductors to maintain the equilibrium of the pelvis, the patient will be tilting toward this side or toward the diseased side. So shortening this lever arm between the body weight and the center of rotation of the hip, reducing this force, and in consequences, the forces coming from the abductor will be reduced, or the forces requested from the abductors will be reduced. So the resultant joint reaction force in total will be reduced. Surgically, how can we reduce the joint reaction force? So the first option we have is to ask the patient, firstly, we can increase the offset. So increasing the offset will do what? Will increase this lever arm. And with increasing this lever arm, this will reduce the stresses over the abductor. So the resultant force will be less. So the resultant joint reaction force will be less. The other option is to increase this offset is to put the hip into varus. So if you do a varus, a proximal femoral osteotomy in varus, what you do with proximal femoral osteotomy in varus, as you can see, if we start with offset from the center here, from the longitudinal axis of the femur to the center of rotation of the hip, as you see, when we do a varus osteotomy, what will happen will increase this offset. Increasing this offset reduces the stresses the abductor needs to exert to maintain the pelvis in equilibrium, because the other limb is fixed, which is the body weight by its lever arm. So if you increase the lever arm of the abductors, this equal you decreasing the stresses requested from the abductors to maintain the equilibrium of the pelvis, and this in total reduce the joint reaction force. What is the other option? Is to move with the same concept, is to move the GT away. So if you do a lateral GT transfer, again, you increasing the lever arm of the abductors. Again, you asking the abductor to exert less forces to maintain equilibrium with the body weight. You, at the end of the day, reducing the total joint reaction force. Last thing, if you're doing your total hip, and as you can see, if you go and look into the stem, all the stems you are using for total hip, you will find that all the stems are in varus unless you request a valgus stem. So the standard stems are all 125-degree angle. So all of them are in varus, just to allow a longer lever arm of the abductor, so allowing less joint reaction force. So what can I tell the patient in the clinic if I want the patient to reduce the joint reaction force? Patient is coming to my clinic with arthritis, and I need to help the patient until I do an operation for him. So I want to advise the patient how to reduce the joint reaction force. Number one, if I ask the patient to have a walking stick on the opposite side, what the walking stick on the opposite side will do, if we go back to this one. So if I have a stick here, what this stick is doing is pushing against my hand. So it giving some forces in this direction, which is anti-clockwise direction. So it actually helping the abductors, so reducing the forces requested from the abductors, so reducing the whole equation, so reducing the joint reaction force. Again, if I want to advise the patient, how can he or she reduce the joint reaction force to get less pain from the arthritis? The first advice will be hold a walking stick in the opposite side. Why in the opposite side? Because imagine with me, this is the patient standing in front of me. His arthritis is in the right side. I asked him to hold the stick in the left side. When he push against the ground, he pushing against the ground, so the actual force is coming from the ground up. Yes? And because it's coming from the ground up, it's going into anti-clockwise direction. And this is the same direction where the abductor exerts the force. So the force requested from the abductor will be less. So the resultant force over the joint, or the joint reaction force, will be less. So the patient will be in less pain. So the progression of arthritis will be less. So the patient will need a total hip in a longer period, not so soon. by the same idea, by the same concept, by the same free body diagram, I can ask the patient to put a weight in his right hand. What if the patient put some weight, like he hold the bag or something? So I advise my patients, if you're going for shopping, keep your shopping bag on the affected side. So if you have arthritis on the right side, hold the shopping bag on the right. If you have arthritis on the left side, hold the shopping bag on the left. Why? Because if he hold the weight here, the weight is pulling in this way. So again, pulling in clockwise, anti-clockwise direction. So helping the abductors. So reducing the forces requested from the abductors. So reducing the whole forces, joint reaction forces going across the joint. That is very important. You need to be concentrating. Remember this free body diagram? Again and again and again. Body weight is coming from this. Have a lever arm between the body diagram, the body weight and the center of rotation of the hip. Abductors on the other side to maintain the pelvis in equilibrium, exerting the same forces. So because of the lever arm of the abductors is shorter than the lever arm of the body weight, the abductors is exerting about 3 times the body weight to maintain the pelvis in equilibrium. And both forces, the force of the abductor exerted from the abductor in anti-clockwise, and forces coming from the body weight in clockwise, together is giving a resultant force across the joint, hip joint, which is called the joint reaction force. How can I reduce a joint reaction force for my total hip? So basically, the options I have, physiological option, firstly, to reduce the body weight. And if I reduce the body weight, means the body weight less, means this side of the equation is less, means the forces requested from the abductor to maintain the equilibrium of the pelvis is less, means the resultant force is less, the joint reaction force is less. That's why if you ask your patient to lose weight, the patient gets a lot of improvement. Many of your patients will become less symptomatic or even asymptomatic with losing a lot of weight. That's why the new concept in the NHS now, any patient which has an osteoarthritis before he can be listed for a total hip replacement, he has to have a proper body weight. And if there is no option by physiological or normal ways, he has to have a bariatric surgery. And to be honest with you, from the experience, once the patient have the bariatric surgery, hip pain or knee pain goes away, and the patient is in a lot symptomatic condition, and even sometimes they don't need the total hip or the total knee. That's why now all the advices, all the recent evidence says don't operate for a total hip or a total knee beyond 35 BMI. And if your patient is beyond 35 BMI, send the patient for a bariatric surgeon. If the patient can need the bariatric surgery, this patient will get a lot of benefit regarding the pain and symptoms on the joint once he reduces the body weight because of this equation. Because reducing body weight, reducing the forces requested from the abductors to maintain the equilibrium of the pelvis, reduce the resultant force in the joint, which is the joint reaction force, so less symptoms of the pain. Okay, so this is physiologically. So first thing, reduce body weight. Second thing, patient does it himself. So if patient have pain on that side, he tend to Trendelenburg or to tilt toward this side. So basically reducing this lever arm, because body weight is the same. Reducing this lever arm, reduce the whole forces coming from the body weight, reduce the whole forces requested from the abductors, reduce the resultant force, and reduce the joint reaction force. Surgically, what can we do? Firstly, we can easily increase the offset. If we're doing a total hip, we can use a varus stem, which is, as I told you, the standard stem, unless you ask for a valgus. If you ask for a standard stem, all the standard stems are in varus. You can create this varus and increase the offset either by laterally displacing the greater trochanter or doing a varus osteotomy of the proximal femur. With varus osteotomy of the proximal femur, as you see, this is the transverse offset. When you do a varus osteotomy, you increase the transverse offset and you increase the lever arm of the abductors, so reduce the forces coming requested from the abductors, reduce the resultant joint reaction force. This is not a common part of the basics of the hip joint, so please give me your attention on that. So now we're speaking about the microstructure of the hip joint. So we know the general structure of the hip joint, the macrostructure of the hip joint. So there is an acetabulum, which is the socket. There is a head, which is the femoral head. There is 3 ligaments, iliofemoral, pubofemoral, and ischiofemoral. There is muscles running across. There is rectus femoris in the front. There is iliopsoas on the medial side. There is iliotibial band and vasti on the lateral side. There is hamstring in the back. This is called the macrostructure. But what about the microstructure of the hip? So they show the microstructure of the hip in the form of a Gothic arch. As you can see, this Gothic arch. So basically, your weight coming on the hip through this a shape like a Gothic arch. So a big circle inside, which is a femoral head, Gothic arch, which what we call the pelvic sourcil. So pelvic sourcil is the weight-bearing part of the pelvis or the acetabulum, which is the acetabular roof. So actually, the weight is not going through the whole acetabulum, but all your weight is going through this condensed area of bone, which we call the acetabular sourcil or the acetabular roof, then going across the weight-bearing area of the head of your femur. That's why if you look into the trabecular system of the proximal femur, you can easily spot that all the trabeculae are organized in a way to get this weight on. So if you see, this is the primary compression trabeculae, and it's aligned in this way because the physiological weight is coming from this side. So the physiological load plays the main role in maintaining the normal structure of your proximal femur, the normal structure of your acetabular sourcil, so maintaining the whole microstructure of the hip. When they go to experimental bovine and getting the bovine head, you can easily see that there is area of high weight and area of low weight. And as you can see, the area of high weight loading, the cartilage is more thicker, is more glistening, is more smooth, rather than the one with low weight. So the microstructure of the hip is the one which is making the normal anatomy and the normal structure of the hip. So weight coming from here, going across the sacroiliac joint, expanded through a triangular bone, which is the acetabular sourcil, then loaded across the cartilage, the articular cartilage, and go across the weight-bearing area of the femoral head. This end by a very condensed part of the triangle of the acetabulum, which is the acetabular sourcil, and going through the head, you can see it maintained the organization of the trabecular system of the proximal femur, mainly the primary compression trabeculae. And as you can see, the cartilage around the head or over the head, even in the animal model, you can easily differentiate between area of high loading and area of low loading. That's why if you look into your femur, area of high loading here will be having a thicker cartilage, will be having a more smooth and glistening cartilage. And this area, which is non-weight bearing, will be having a more thin and a different structure cartilage. To complete the microstructure of the hip, you need to understand the angles, why this sourcil will be doing the job. For this sourcil to do the job, it has to be covering the whole part of the weight-bearing area of the femur. So you have to have an acetabular index of 30 or below, 30 degrees or below. And it's basically, if you have the teardrop line and you run a line from the teardrop to the tip of or the lateral border of the acetabulum, this angle needs to be 30 or less, so you can maintain an enough coverage by the sourcil to your femoral head, and so you have a normal weight-bearing area. We understand from the old basics, from the old basic science, that forces are stresses over a surface area. So stresses, which is the body weight, is the same. The more you increase the surface area, the more you reduce the stresses over the area or the forces over the area. So body weight forces is coming this way. If you have enough coverage from the acetabular sourcil, you have enough area of weight bearing in the femur, you spreading the weight over a large surface area, you're reducing the contact stresses, so you're maintaining your hip for a longer period. That's why when the patient comes early with an arthritis in the hip, you have to look into these angles. So this is the central edge angle, again doing the same job, giving you an idea how much lateral coverage of the acetabulum over the femoral head. So if you have the acetabular index angle, if you have the central edge angle abnormal or reduced, means there is not enough acetabular sourcil to put weight on the femoral head. This means condensation of the weight over a smaller surface area of the sourcil. So your options to reduce the progression of osteoarthritis is to do some osteotomy, periacetabular osteotomy, and I will show it to you in a coming slide. An easy spotting here, you can see a normal sourcil. So enough coverage of the acetabular sourcil over the head. Now this is shallow acetabulum. This means the sourcil or the weight-bearing area of the acetabulum is smaller. So the stresses are very high. So as you can see, it's more sclerotic. So this sourcil is more sclerotic compared to this one. The area of the head is more sclerotic compared to this one. and this gives you an idea that the stresses coming across this is much higher than the stresses coming across this, and definitely this is much and much worse. When you go with the scope, when you go, any one of you who did a hip scope before, when you go with the hip scope, you see a lateral sourcil, you see a medial sourcil, you see a middle sourcil, and you see a medial sourcil with a fovea. And the area between the fovea, which is the medial sourcil, an area with the lateral border or lateral edge of the acetabulum, which is the lateral sourcil, this is the weight-bearing area. This is the actual weight-bearing area from the acetabulum as a sourcil, or from the femoral head as a weight-bearing area. If this area is smaller because of a shallow acetabulum or any reason, like the kids with DDH or whatever the reason which makes the sourcil smaller, this means condensation or increasing the stresses because of the smaller surface area, and this end by more stresses over this area and early arthritis. And that's why when you have a loco in the patient, the early area to get arthritis is this area, and the last area to get arthritis is the central area. That's why central arthritis is a severe form of arthritis. So based on that, if we have abnormal microstructure of the hip joint and we want to regain the Gothic arch, we need to regain enough sourcil covering the femoral head or the weight-bearing area of the femoral head. We may think about osteomatizing the femur or osteomatizing the pelvis. The idea from this is to regain the microstructure of the hip, to regain enough contact surfaces, so reduce the surface area of the forces of the body weight, so reduce the joint reaction force, and improving the pain and reducing the arthritis. Okay, so how can we do that? You have multiple options. We're not in a stage now to explain to you every acetabular or periacetabular osteotomy, but basically it is a periacetabular because we don't cut through the acetabulum. That's why all of them, you can get the patient to weight bear straight away. All of them are stable. And you have either the option to do 2 cuts, so cut above and cut below, and this is the least stable, or do 3 cuts, so going from the ilium or supraacetabular, going superior pubic ramus, inferior pubic ramus, or you can do a whole periacetabular osteotomy, so going through the superior inferior pubic rami, acetabular at ischial body, and going back from supraacetabular and what's called the Gans osteotomy. So you can move the whole acetabulum, so get the maximum coverage of the femoral head, so get the maximum surface area for weight-bearing or weight-bearing forces, so reducing the stresses over the weight-bearing area. On the other hand, you can do the same, but from the femoral side. So if your femur is in a lot of valgus, like a dysplastic hip, so you need to, because if it's with a dysplastic hip, if you imagine that the femoral head is going in a lot of valgus, this means the area of weight bearing, firstly, not in the normal situation, is over the fovea or over the medial head. Number 2, it has very small area. So we need to pull the ball back into the socket so we can maintain the microstructure of the hip. And you can do that by varus realignment osteotomy of the proximal femur. And other way around, if the proximal femur is in coxa vara and the femoral head is all inside the acetabulum, so the head, the upper head or the superior head, rather than the weight-bearing area, is not ready to remove to adapt any weight-bearing. So that's why you need to get the weight-bearing area again under the sourcil to maintain the Gothic arch relation or the microstructure of the hip. So you do a valgus osteotomy, valgus realignment osteotomy of the proximal femur. So the idea from the osteotomies, either periacetabular or femoral, is to regain the microstructure of the hip. So regain the Gothic arch relation, which is a sourcil, which is like a triangular area, like the thigh cap. If you remember the cap from the thigh people capping over a weight-bearing area of the head. You don't need neither the lateral head nor the medial head. So you need enough sourcil, enough acetabular sourcil over a proper weight-bearing area of the femoral head to have a normal microstructure of the hip and a normal Gothic arch relation. If my acetabulum is shallow, so tonus angle is less, acetabular index is less, central edge angle is less, so all what I need is to do a periacetabular osteotomy to pull the acetabulum back to sit over the head. So give me enough surface area to load with the weight. So reduce the forces going across this weight-bearing area. If my femur is in valgus, so very shallow area holding the weight, so I do a varus realignment osteotomy to pull the femur head back into the socket, so maintain the Gothic arch or the microstructure. And same if the patient has a coxa vara, so means the head is all inside the acetabulum, so you're actually loading the lateral head then more than the weight-bearing area. So all what you need is to pull back the weight-bearing area under the sourcil. That's why you do a valgus realignment osteotomy. Coming to total hip, which is the main aim of our course and our lecture, and we cannot speak about the total hip without mentioning Prof. Charnley or Sir Charnley. So you have to understand that all the hip, all the replacement, all the joint arthroplasty or all the joint replacement is mainly pain management procedures. So we mainly aiming for patient with osteoarthritis, severe pain in the joint. We aim to get this pain away. So mainly is pain. That is why never ever to touch a patient who is no symptoms or painless. We're not treating X-rays. We're treating a patient. So never touch a patient with total hip or total knee replacement without really severe arthritis. Your patient which you will operate on with mild arthritis, with moderate arthritis, with no arthritis, or even with arthritis which is asymptomatic, I promise you this patient will never be happy. For the patient to get the best outcome from the operation, you need, and he needs to understand, and you need to educate your patient that total replacement of a joint is mainly a pain management procedure. So I'm doing this for your pain. Yes, I will improve your function. Yes, I can improve the alignment. Yes, I can restore the anatomy. Yes, I can restore your leg length. But all of these are additional benefits. The main benefit of any replacement is to get pain away. So it is pain management procedure. No pain, no gain. If patient not in pain, if patient not symptomatic enough, please don't touch the patient with your knife. Otherwise, this patient will never be happy. So Sir Charnley in the 60s has a revolutionary idea of the low friction. He went through many stages in his way on his career to get the total hip replacement to what we see now. So starting from big friction and big heads, starting from an idea of taper slip, which I will explain you in a minute, then moving from this to a area of a stem with a composite beam and a smaller head, which is exerting low friction movement and exerting and getting the idea of low friction arthroplasty. So you have to understand that our problem with the total hip, or it's not a problem, it's our fight with the total hip, is coming into 3 points, which is longevity, stability, and wear. And you need to be very careful and be very smart when you're dealing with 3 of them. You may play with the longevity, try to get a very long life implant, but remember that it's not only about long life, it's about to be a stable implant, not dislocating every day, and to be an implant with less wear and less problems, less symptoms, less complications. Because at the end of the day, you've done the operation to get your patient to a better position. On the other side, I mean look into the stability and all my idea, my thinking about the stability. How can I get a stable total hip replacement? But remember, you may end by getting a stable total hip replacement, which doesn't live enough, and patient needs a revision very soon, and same for the wear. So it's 3 intersecting principles: longevity, stability, and wear. And this is where all the arthroplasty surgeon from before Charnley and after Charnley is playing between getting better development of total hip, better implant, aiming to get these 3 points covered: longevity, stability, and wear. And we'll speak about each one of them separately. Give me all your attention because every word of this carries a meaning. So first thing to speak about is Charnley low friction arthroplasty principle. And when you look into Charnley stem, this is the Charnley stem. So idea of Charnley was he was doing a cemented cups, and he was doing a cemented stem. And his idea was he need to get a whole stable construct. And this stable construct lives for as much long as possible. To do that, he was using early large heads, start using small heads, aiming that this small head, as you can see here, will be doing less friction with the acetabular insert, which is a plastic, which is a polyethylene. And based on the less friction, there will be less stresses on the bone bone cement interface. So this cup will live long. So Charnley low friction arthroplasty principle was directed mainly to longevity. He aims by his principle is to use a small head. Using this small head, the 22.5, this will exert less friction between the head and the liner or the insert, and this by consequence will reduce the movement of the liner against the cup, which will reduce the movement of the cup against the cement interface. And from his point of view, this will reduce the friction and ending by long life acetabular cup. Did the idea work? Yes, it did work perfectly. And anyone who is doing arthroplasty can see that the Charnley arthroplasties are still alive till today, while our very nicely newly developed arthroplasty fails after a few months. So the idea did work. Yes, the idea did work. So for him to reduce the joint reaction force from the idea we just mentioned a few minutes ago, he was doing regularly a lateral transfer of the GT. So as you can see here, he has a composite beam implant with a shoulder and using a small head, which is it's monoblock, using a small head, so less friction between the head and the acetabular liner, less friction between the acetabular liner and the cup, less movement between the cup or stresses between the cup and the cement interface, means he was able to maintain cups as long as possible. For him to avoid or to give more longevity to his hip, to avoid high contact stresses or high joint reaction force on his hip, he was regularly transferring the GT or the greater tubercle laterally, so he can maintain a long lever arm of the abductors. So as we agreed minutes ago, that reducing the lever arm of the abductors means the whole total force coming from the abductor will be less, means the whole joint reaction force will be less, means this hip will be exposed to less joint reaction force and less stresses, and by definition, this will give the hip more longevity. Other principle, he was aiming with the small head and making the liner a bit shallow liner or a bit thin liner, is to medializing the center of rotation of the hip. So as you can see, the center of rotation will, for this hip, for the Charnley, the original Charnley hip, will be in the center of this head. And since it is the center of this head, you can see easily he has medialized the center of rotation. So again, has reduced the lever arm of the body weight. So reduces the stresses coming from the body weight. So reduces the stresses coming from the abductor to maintain the pelvis in equilibrium in front of the body weight forces. So reduce the joint reaction force. So what did Charnley do with the low friction arthroplasty principle? Number one, he used the small head, so less friction between the head and the insert, so less stresses over the cup cement interface, so more longevity for the cup. Number two, he medializing the center of rotation of the head, so using a bit shallow insert. Early days, he was using a thick insert, considering that this, even with wear, will live long. But after that, he changed his mind because he understands that it is more mechanical. It's not about the material itself. So he started to use more shallow insert, so allow the center of rotation of the head to be medialized. And when it's medialized, this means shorter lever arm of the body weight, less stresses from the body weight, less in front stresses from the abductors, less total joint reaction force. What about the abductors? For the abductors, he was doing regularly a GT transfer laterally, so increasing the lever arm of the abductor, reduce the stresses needed from the abductor to maintain the pelvis equilibrium, reduce the joint reaction force. So the 3 points: medializing the center of rotation, lateralizing the GT, and doing using a low friction or a small head, all of them aiming to longevity, aiming to maintain his hips longer. To understand the idea of the friction, you have to understand what is the frictional torque. In simple non-architectural ideas, if you have two surfaces running against each other, any smooth surface running against another smooth surface, there is a friction force come between them. This force is always reducing energy, reducing heat. So very simple way, if you move your hands against each other, there is friction happening, which means every surface is resisting the other surface. And this is ending by friction forces, which is producing energy or heat. So as a hip replacement, we have ball and socket. So there will be always a friction, and this friction, if it is a high frictional forces, it may reduce a torque, means it may move the acetabulum from the cement interface and may add an extra layer of stresses over the cement interface. So from this idea, Charnley understands that he needs to reduce the friction between the bearing surface or the surface he is using for his hip replacement. So he started to think about, rather than putting hard on hard, getting hard on soft. So rather than using metal on metal, use metal on polyethylene. He starts thinking about using a smaller head rather than a larger head. He starts thinking about decreasing the forces running across the joint by both options, medializing the center of rotation or lateralizing the GT. Nowadays, we got from the idea from Charnley and we start working on it rather than changing the structure or the shape of or the conformation of the surface. We can play with the material itself. We can use materials which has low friction, like the ceramic, like the cobalt chrome, like the steel is very well finished, is very polished. So there is less friction between them. So this exerts less torque. So doing the same job as the low friction arthroplasty idea of Charnley. Number two, we're still using the Charnley idea about the femoral head size. So nowadays, if you mainly looking into longevity, not stability, you still can use a smaller head. And there is a lot of arthroplasty surgeon who still keeping doing a 28 head, using a 28 mm head rather than using a larger head. And here I need to give you a bit of experience tip. When you're doing an arthroplasty and you are in front of a case for a total hip and you are in a position to choose the head size, you put your stem in, then the staff nurse or whoever is circulating asking you what size of head do you want. You have two options, either to get a large head, and if you get a large head, this will equal a smaller liner. So at that time, the idea of large head is to maintain a very good arc of motion, a very good jump distance, and I will explain you this in a minute. And this will give your hip better range of motion and reduce the risk of dislocation, so give you a more stability on behalf of longevity. Because larger head, smaller liner means the smaller liner will wear very early. Larger head with a smaller liner means more friction, means more torque, means more stresses over the cup bone interface if you're doing a cementless, or cup cement interface if you're doing a cemented. On the other side, if I'm operating on a patient which is 90 years old, 80 years old, all my idea here, he's low functioning. So I'm not worried about the stability. All my worry is about longevity. I need to give him a hip which supplies him with good 20 years of relief. So if he's 80, he's not, he will not be exposed to another revision. So in an old age with low function, my main concern is longevity. In a young age with high function, my main concern is stability. That's why I'm the same surgeon doing the same type of hip using the same implant or the same company. With a patient, I'm using a 36 head is a small liner, and another patient, I'm using a 28 head on a larger liner. And you have to be understanding that this is your balance between longevity and stability. If you want more longevity, you have to go for a smaller head, larger liner. If you want to go to more stability and you don't care about the longevity, you go for a larger head on a smaller liner. Third thing is femoral polyethylene thickness, and this is goes with the femoral head in consequence. So smaller head equal large thickness of polyethylene, larger head equal a small thickness of polyethylene. Then the last thing is to think about the position of your implant. So one of the things which determine what will be the frictional torque of your hip arthroplasty is your surgical technique. How come my surgical technique it changes the frictional torque of the hip arthroplasty? Imagine with me, you put your hip in, everything was organized, is done properly, but all what you done and you have open your cup. So you put your cup a bit open, means it's in a higher inclination. So you're putting your cup in about 50-degree inclination. What will happen? You will end by the weight bearing area at the edge of the cup, and this is what's called edge loading. So you yourself has make a smaller area of friction between the two surfaces. So you make the frictional torque higher. So you actually change the frictional torque by the inclination of your cup. Another example, you put your hip in, your cup is nicely inclined, your cup is nicely everted or in a nice version, but you have done a very, very tight soft tissue. So soft tissue tension is very high. So soft tension is high. Will definitely help the stability. With a higher soft tissue tension, the hip is stable. But on the other side, the hip is nicely compressed. So the two bearing surfaces, which is moving against each other under a lot of stress, higher friction, higher torque, higher loosening. Again, so frictional torque, you need to understand two surfaces moving against each other. There is frictional moment happen between them, and this frictional moment end by a torque on both of them. So this idea guides you to how can you think about your total hip. Do I need my total hip living long, even on behalf of stability and range of motion, or I need my total hip stable, giving the patient a good range of motion, even it will not live long? So you can change this by choosing the material of the bearing surface itself, choosing the femoral head size as I explained you, choosing in consequence the polyethylene thickness, and lastly your surgical technique. So if I'm going to a patient with a young patient with higher level of activity, higher level of function, so as we agreed, I will be using a larger head, 36 head, smaller liner. Yes, smaller liner. I will be very meticulous in my inclination and version. So I maintain a good inclination and version of the cup. And at the end of the day, I will be doing putting the patient in a good soft tissue tension, so I'm sure that my hip is stable. What if I have an old patient with low activity? We agreed that I will be putting a small head, so low friction tool. I will be putting a thicker liner, so more chance for if wear happens, it takes time before it's worn completely. And number three, my meticulous technique will be again maintain inclination and version, but I will be more careful about increasing inclination. I want this patient to have a larger surface area of friction. And my surgical technique, I will not be putting any tension over the soft tissue because I don't want to increase the friction torque between the two surfaces, because I don't want this torque to be transferred from the cup to the cup bone seam interface or the or the cup cement interface, because I want my hip in this old low active patient to live as long as possible. I hope this is clear for you. If it's not clear, just write me in the chat and I can repeat it. So this is how we think about the longevity. As we agree, as we understand, there is an intersection between longevity and stability. When I come to the stability, I have to understand that the stability is depending on multiple factors. Most of these factors is depending on me as a surgeon, on my surgical technique. So the approach defines the stability. Evidence is a lot of debates in the evidence between anterior approach, posterior approach, lateral approach. Nearly most of the evidence agrees that the anterior approach is the most stable, but on behalf of risk of fracture, on behalf of learning curve, on behalf of special instrumentation, on behalf of nerve injury. But if we come to the point of stability, so the anterior approach to the hip is the most, is the least at risk of dislocation. So by definition, is end by the most stable hip. Number two after the approach is the arc of motion and jump distance. And if you understand the idea of the jump distance and arc of motion, if you put, as you see, if you put a large head on a large cup, you see the arc of motion of this head before it comes out of the cup is big, because it depends on the equator of this head. So if your head is big, this gives you a big arc of motion before this head will come out of the socket or come out of the cup. So it gives you a better range of motion and gives you more stability. So again, the same idea. If I'm aiming for a stability, please go for a large head. If you don't care about longevity, if you care about longevity over stability, go for a smaller head. Smaller head means a smaller arc of motion, means early jump and early dislocation. And this is the arc of motion explanation. If I have a smaller head, my arc will be that. Before, if you see, so from the most extreme position, when if I go more than this head will come out. And if I go more than this, the head will come out this way. So the arc of motion between the extreme abduction against the extreme adduction is that one, is about 100 degrees. While if I use a large head, as you can see, the maximum for me to get this head out in abduction compared to the maximum I can get this hip out in adduction is a wide and large arc of motion. So the bigger your head, the larger the arc of motion, the longer the jump distance between this head jump out of the socket. So if you're using a small head, you understand, yes, I'm maintaining a bigger or thicker liner. Yes, I'm maintaining a long life hip, but I'm decreasing the range of motion and I'm compromising the stability. On the other side, if I'm using a large head, so a smaller liner, so this large head over the smaller liner will give me less longevity because higher friction. But on the other side, it gives me a good arc of motion, which means better range of motion of the hip, and a more stable hip, because before this head jump out of the socket, it needs to move all the way up or all the way down. And the larger the head, the larger the arc of motion, the larger the jump distance, and the less risk of dislocation, the better range of motion. What can I add more? Use a liner, as you can see, use a lipped liner, which has a lip, which basically extend the boundaries of this acetabular cup by either a 10 degrees lip, which you can use it in any direction. So if I'm worried about anterior, I'm opening a posterior approach, I'm worried about anterior stability, I'm sorry, posterior stability, I'll put this lip in the back. I'm opening an anterolateral approach, I'm worried about anterior stability, I will add this lip to the front or superior. So the lip liner, the idea of lip liner is to extend for you this curve. So extend this curve with 1 or 2 lip on both sides, and increasing the curve will give you more stability. The least is to have a constrained implant, something like a dual mobility, which is having head inside head. So this is the smaller head is the one attached to the stem. So it has 3 layers of constraint. That's why the dual mobility is the answer if you have an unstable hip. Orientation, as we agreed from the start, again, your surgical technique is very important, because if you change your inclination, keep an open cup or small or a closed cup or a verted cup, anti-verted or retroverted cup, this is end by a higher stresses over the joint, a higher joint reaction force, and ending by your hip dying early. One of the very common problems and very missed is the spinopelvic mechanics. You need to understand the mechanical relation between your spine and your pelvis. So the movement is coming, you understand the curves, you understand that your cervical curve is lordotic, then the thoracic curve is kyphotic, then the lumbar curve is lordotic, then the sacral curve is kyphotic again, and lordotic. And you need to understand that there is a sacroiliac joint which makes a relation between your sacral spine and the pelvis. And if this area of the spine, which is the lower lumbar and sacral spine, or the sacroiliac joint is arthritic or spondylotic, means the spinopelvic motion is not normal, means you need more motion coming from your total hip before the hip dislocates. Remember, hip is not always a cup, it's not only a head inside the cup, it's a cup over a head. So you need to be careful about the movement from the femur and movement from the spine and pelvis. If you have a patient, have a look nicely in the x-ray, and if you see a patient coming with for a total hip with a spinopelvic problem like spondylotic changes, like sacroiliac arthritis, anything ankylosing by any reason, ankylosing spondylitis, remember that the concern in this patient that there is no normal spinopelvic motion means you have to have a good range of movement from your hip. You had to have a good stability and cover for your head, otherwise your total hip will fail. Lastly is the patient factor, because patient factor affect all of this. So if the patient is obese, if the patient is short, if the patient is big, if the patient pelvis has any sort of abnormality, if the patient doing special activity or need a more activity or more forces or more function from the hip, this definitely affect the stability. So if I have a patient who is very active, I'm keen to give him a very good range of motion. Remember, you're giving him a good range of motion on behalf of the stability. So longevity, stability, and wear are 3 intersecting areas. And if you don't look carefully what you need from the patient and what you will compromise, you will give your patient the wrong choice, and this will end by a failing total hip replacement. And as you can see, this is the aim of any hip replacement you do. You need hip replaced, which is at equal length to the other side, unless you plan something different. You need a hip with maintained normal offset. So by this picture, you're maintaining all the relation between the hip and the stem and the cup. So you're maintaining a normal joint reaction force. So your hip should live long. If we come to the wear, the third arm of the equation, or the third ring, which is intersecting with longevity and stability. When we speak about the wear is a big take. It's a lot to understand about the wear. In a simple term, wear is an unintended loss of the material. So if your material, you're losing your material, you're having a wear. This wear could happen chemically, it could happen mechanically, it could happen electrically. So what we aim here is to speak about the mechanical wear, which is where because of a mechanical problem. We don't care about the chemical wear, we don't care about the electrical wear. So where to understand the wear, to understand how much I will be losing from the material of my total hip replacement, I need to understand the different biomaterials and how every one of them has a wear properties, because the wear properties of each bearing material makes a lot of difference for the longevity of my total hip. Remember, with every part, we speak about the other. So we're speaking about where you will find me mentioning stability a lot, mentioning longevity a lot. Same for longevity, same for stability. So again, where is unintended loss of the material? You lose this material because of chemical or mechanical causes. We're now speaking about the mechanical causes. One of the mechanical causes is the wear properties of your material you're using in the total hip. Number 2 is the friction and lubrication. Number 3, as we just mentioned a minute ago, is the soft tissue tension and the friction torque. Number 4 is your surgical technique, especially if you leave a foreign body, if you don't wash enough, if you don't put a proper inclination and rotation of your implant. So the 2 types of lubrication we have. So basically, lubrication in simple terms is that there is a fluid film between 2 surfaces reducing the friction. So lubrication is the way to reduce friction. You understand it in a very simple manner. 2 surfaces are fricking against each other, or there is a friction torque between them. If you want to reduce the friction torque, you have to put a lubricant between them. And the lubrication for the total hip happen in 2 forms. The good form, which we all wait for, is this fluid film form. Means the surface is much more smoother. There is no asperities, no many asperities from the surface. Means there is a whole film of lubricant between the surfaces. This equal this low friction between these 2 surfaces. What if my material is has a lot of notches, is not very well conformed, is not very well polished, so it's not a smooth surface? This will end with, as you can, a lot of asperities or a lot of prominence, and so you will find some areas without a lubrication, without a lubricant. So this is what we call a boundary film lubrication. So for our total hip replacement, we aim to see this picture, which is a fluid film lubrication, and we can see this by a good wear properties of a material, good wettability of a material, good lubrication of the material. The good lubrication means this material surface is very smooth. There is much less prominence or asperities. So the lubricant can make a fluid film lubrication between the 2 surfaces. Means friction will be less between these 2 surfaces. What if my material is not sensitive, is not that smooth, it has a lot of asperities? This will end by the material areas without any lubrication, as you can see. So there is some lubricant between some of the surfaces, but most of the surface has no lubricant between each other, and this will end by a boundary film, which we don't like to see in a total hip replacement. And easily you can see here. So what happened here, if you can see, this head is not central into the cup. So basically the head has migrated up. This gives you an impression that this total hip has a plastic wear or has a polyethylene wear, and you can easily spot how much osteolysis is there from the wear. And if you see here in a ceramic head, you can see what we call the stripe wear, which basically, because the orientation of your cup, you put your cup a bit open. So rather than the head is just holding over a good sourcil from the cup, the head is edge loading, and because it's edge loading, you have this stripe wear. Okay, so if we go to the total hip as a component, so we will go about the basics of the acetabular component, then the basics of the femoral component. The basics of the acetabular component is basically how we choose the material of the component. So the options for the acetabular component is either to be a cemented or a cementless. All days cemented was the main way of fixation for the acetabulum, and nowadays the cementless is the one. Although the NGR says that the cemented, NGR up to 24 is saying that the cemented cups are still living longer than uncemented cup. I know that every practice in the UK and around the world is doing uncemented cup until proven otherwise. But I can tell you that the NGR till the moment say that the best or the long life implant is extra stem on marathon cup, which is a cemented cup. That's a bit a surprise for myself when I read it first time, and will be surprising for you. But I can assure you that the cemented cups are still working. So why we move from a cemented cup to a cementless cup? Basically, we all understand that the cement is an inorganic material which is polymethyl methacrylate, and this material is very good in compression and very bad in shear. So your cement is doing a very good job when you put compression over it, and doing a very bad job when you put shear over it. And because all the forces going across the acetabulum is shear forces, that's why we thought that we have to move from a cemented cup to uncemented or cementless cup. So as you see, if I put my cup, this is my acetabulum. If I put my acetabulum inside my pelvis, all the forces are shear forces. So we understand, we agree, we know that the cement does well with this compression, doesn't do well with the shear forces. And because we know that the acetabulum will have a shear forces, that's why we have moved from using cemented cups to cementless cup. Okay, so if I'm planning to use a cemented implant or cemented cup, how will this be different in the material if I plan to use an uncemented cup? If you plan to use a cemented cup, so what you need is as much low forces going across your cement interface. So you need to use a material which is adapt much stresses before it transfers these stresses across to the bone. So that's why you can see we're using always a polyethylene cup when we're doing a cemented. This polyethylene cup has a lot of features, which I'll explain you in a minute. It has phalange there, it has a lot of grooves, it has some buds to maintain to hold the cup in place and maintain the stability. But if I'm using an uncemented cup, so I need a material which have nearly the same youngest modulus of elasticity of the bone, so it doesn't take all the stresses of the bone, so it doesn't cause any stress shielding problems. That's why we're using this cobalt chrome or titanium. Cobalt chrome or titanium. I'm sorry, titanium cups when we're doing a cementless total hip. So again, cemented or cementless, both of them doing well. Cementless are the most common now used. Cemented still has the best longevity in the NGR. Material will be different, so I will be using a total polyethylene cup if I'm doing a cemented. I'll be using a titanium cup or a cobalt chrome cup accordingly if I'm doing a cementless. The commonest in the market, which is the Trident, it is a titanium cup. So what you need to know that the longevity of your cup is not only about the material, it's again about your surgical technique and orientation of your cup. You need to put your cup in a proper inclination of which about 40 to 45 degrees, and you need to put the cup in a proper version according to what approach you opened, and you need to get this cup holding into the bone before you go out, because if your cup is not stable, it will never be stable. And again, another tip here, remember that the position you will leave the cup on the table will be the position of the cup unless it become loose. So material we agreed will be according to what cup I'm using, cemented or cementless. Again, we agreed that the cup needs to be in a proper orientation. Then how will we fix the cup? So if we use an uncemented cup, we depend on the idea or the principle of breast fitting. And basically breast fitting means I get a bone ongrowth over this cup when it goes inside the bone. So I go with my reamer, I make a hole which is smaller than the cup, then I get the cup to breast fit inside the bone and get until the bone ongrowth over the cup comes. And to make this as much efficient as possible, we use the cups covered by hydroxy polyethylene. So hydroxyapatite coat, I'm sorry. So fixation, either cemented or cementless. Cementless is depending on the breast fitting. So reaming to a smaller size than the actual cup. So the cup go inside the bone as press fitting. and it has hydroxy apatite coating, and this hydroxy apatite coating allow bone ongrowth over the acetabulum cup, so maintain the acetabulum cup in place. Okay, so if we go to the cemented cup, it's a totally different story. So I'm depending on cementing. That's why I'm making a bigger hole in the cup. And because I'm making a bigger hole than the cup, I'm using a cup, as I told you, it's a polyethylene cup. I need to have a flange. This flange will maintain all the cement inside. I need to have grooves, and this grooves is increasing the surface area and bonding. And I need to have the boards, and this boards is just holding inside the bone, so maintain the stability of the cup. Sorry guys, give me just 1 minute. Sorry. Sorry. So uncemented and cemented cup. So again, uncemented cup is depending on uncemmented cup is depending on the brace fitting idea. So never depend on the screw fixation. So if your cup, uncemented cup, is not brace fitting, is not holding, don't wait for the screws to maintain its stability. If you depend on the screws to maintain the stability, this cup will be moving later on once the patient starts to put weight on it, and this total hip will fail. So uncemented cup equal a brace fitting cup. If my cup is not stable and brace fitting, I will not use screws. So why we have screws? We have the screws just to maintain the rotation. So if I'm worried about my cup rotating, I can use the screws. But screws in its own will not fix your cup, the uncemented cup. Okay, if I'm using a cemented cup, not uncemented, so I'll be using cement. So my cup has to have a special configuration. It's mostly a polyethylene cup. And what happened, it has large keyholes, and this large keyhole is maintaining the subchondral plate and giving more and more stronger stability. So rather than just the surface is the cement interface is just the surface, no, it's surface and holes. And it has 3 items of fixation, 3 items of stability. Number 1, flange, which is the outer cover, which is this one. And this flange basically is compressing the cement in, so adding more stability. Number 2, it has some grooves, and you can easily spot that these grooves is increasing the surface area. So more and larger cement cup interface. Then the third thing is some buds, and these buds is mainly to avoid bottoming out. So basically holding into the bone, so it doesn't allow any bottoming out. So you have flanges, you have grooves, and you have buds for the cemented cup. For uncemented cup, again, please don't depend on the screw fixation. Get your cup brace fitting first before you use the screw fixation as a way of stopping rotation or avoiding rotation. When we come to the femoral component, again, the femoral component, the key elements of it, it has a stem, as we all understand. It has a tip, it has a shoulder, and it has a trunnion, and definitely it will have a head when you put the head on. The common and the most commonly used, the extra stem, is a double tapered stem. What means by a double tapered? But double tapered means it has a differential size, so it's different from side to side. So, and the first taper is, if you look to the stem, to the extra stem from the side, you can easily spot that it is bigger proximal than distal. So it's tapering from proximal to distal. So this is one taper. The second taper is, if you look it from back, or if you look it anteroposterior, you can see easily it is again tapering from proximal to distal. So this is a second taper. And the third taper is in the transverse plane, in the axial plane. If you look axially into the stem, you will find that the stem is tapering from lateral to medial. So tapered stem, and we speak now about the principle why we get this stem tapered. You need to understand that tapered stem could be single tapered, could be double tapered, could be triple tapered. So single taper, which is, as all of us know, all our stems are differential in size between proximal and distal. If it is double tapered, you will look from back front, you will see that the stem is proximally bigger or broader than distal. And if it is triple tapered, if you look into the axial plane, you will see that your stem is tapered from lateral to medial, or it is broader at lateral border than medial border. What's the idea of taper? The idea of taper will take us to the idea of the fixation, and we'll speak about this in a minute. So what I need from my stem, I need from my stem to have a good fixation, to have enough hold in the femur, to be centralized, so not depending on medial or lateral cortex. I need from it to have a large offset. I need from it to have a trunnion, which gives a good hold to the head. This is the ideal I need from my femoral stem. So to get a good fix in the femur, we need to understand that the femoral fixation is 2 types. Either we're doing a cemented or uncemented. If we're doing a cemented, so we're aiming that there will be a stem cement interface, a cement bone interface. And again, for the longevity, we need to maintain the torque or the movement or the stresses at these two interfaces. If we're doing an uncemented or cementless, so we're getting again the stem to breastfeed into the bone, maintain or allowing either bone ingrowth or bone on growth. Okay, how this will make a difference in the material. So if I decide that fixation way will be a cementless fixation, so actually I'm breastfeeding fitting a stem inside the bone. If this stem is very, very rigid, if this stem is like cobalt chrome, what will happen? The stem will take all the stresses going to the proximal femur. This means my proximal femur will be stress shielded, and this will end by a very weak proximal femur, which will break at some point. That's why when you look into the cementless stems or the uncemented stems, you will find that most of them are titanium. Why titanium? Because titanium has the nearest youngest modulus of elasticity to the bone with some strength. And I am by the titanium is for the bone to share in the stresses coming on the proximal femur. So titanium will not do a stress shielding of the proximal femur. So my proximal femur will be equally loaded. So my proximal femur will not be weak or get broken. Other way around, if I'm doing a cemented fixation, my aim is to reduce the stresses between the stem and the cement and between the cement and the bone. So I'll be using a very rigid material, and the commonest we're using either stainless steel or cobalt chrome. So material will be decided depend on what way of fixation I'm going to use. If I'm going to cementless, I'm using a material which is near to the bone and youngest modulus of elasticity, so will not get all the load away from the bone, so will give the bone some load, so it'll be load sharing, so allow the proximal femur to maintain bone structure and strength. If I'm going to cemented, so I need my stem to get all the stresses, reduce the stresses on the interface between a stem and cement and bone. So I'll be using a very stiff material like cobalt chrome or stainless steel. Okay. Coming to the cemented. So cemented idea, if I go for a cemented stem, the cemented idea has moved by three stations. Station number one, when Charnley started his idea of total hip arthroplasty, he was using what's called taper slip. What taper slip? From the name, because your stem is tapered in different planes, either single taper, double taper, or triple taper. The cement will be covering the endosteum, and because of the taper, this will allow a controlled subsidence of your or slip of your stem inside the cement. Why I will allow a slip or a controlled subsidence of my stem inside the cement? To get the idea of what's called Hope stresses. And Hope stresses is basically if you have a closed circle or a closed cylinder, and within the closed cylinder, if you put stresses inside the closed cylinder, what will happen? This will be exerting Hope stresses or compression stresses all over the walls. And this gives the stem more stability. So when Charnley started the idea of total hip replacement, he thought about taper slip. He make his stems with single taper, means it is broader proximal than distal in the coronal plane. And when he put the cement in, because of the tapering, the stem will slip, or the stem will be controlled subsiding inside the cement. So it's more fitting, applying Hope stresses on the inside of the cylinder, which is the bone, and this will give it a more stability. What about the composite beam? Then he started to think that, oh, why not to get this structure composite from the start? So I will get my stem non-tapered, very smooth, very sliding from outside, coated from our side with glistening material, and this is, I will end by my stem maintained inside the cement with no controlled subsidence or slip, and this will give me at the end of the day a whole stable construct. This is the idea of the composite beam. So the idea of the composite beam, that I will make a stem which is smooth, slim, non-tapered, goes inside the cement from the start, making the stem, cement, and bone as a one piece, as a one composite. Nowadays, we moved back to the old idea of Charnley, which is the taper slip. That's why every stem in your hand today, if you're doing a cemented hip arthroplasty, exter, C-stem, whatever you're using as a cemented stem, you will find it either single tapered. Most of them now is double tapered or triple tapered, and most of them depend on the idea of controlled subsidence and hope stresses, or what's called the taper slip. I hope this is clear for you. So we had our stem fixed in the femur, either cemented or cementless, and if it's cemented, either by composite beam or by taper slip. We got our cup fixed, cemented or cementless, and we agreed that if it's cementless, we have to be brace fitting. We may add some screws to control the rotation. If it is cemented, it needs to be properly aligned and oriented, and it needs to have a proper cementing. Now I get a fixed component in the acetabulum side, a fixed component on the hip or the femoral side. The idea now is the connection between the stem and the cup, which is the bearing surface. And the bearing surface, from the idea of Charnley, from the idea of Charnley, he started with the idea that he doesn't get any bearing, he just get hard on hard. So bone on bone, metal on metal, metal on metal. Then he started to understand that getting hard on hard has a lot of problems. That's why he started to move from hard to hard to use hard on soft, which is metal on polyethylene. So the options we have for the bearing surface, either to be hard on hard, and the two examples on this, ceramic on ceramic, or metal on metal. The other option is to have soft on hard, which will be ceramic on poly or metal on poly. And the commonest we're using now is hard on soft, which is mostly most of in our trusts and our institutes is metal on poly. Okay, so what is the benefits and risks, or what is the advantage and disadvantage of using hard on hard? And what's the advantage and disadvantage of using soft on hard? And if we're using hard on hard, what is the advantage and disadvantage of using ceramic on ceramic over metal on metal, or metal on metal over ceramic on ceramic? So if you look into the ceramic on ceramic, the advantage is the ceramic, as we know, all of us, is very strong. That's why we're using in our flooring everywhere. It is stiff, it's hard, and you need to clearly understand the difference between the three words. For us, as a non-engineering people, stiff is strong as hard. No. From engineering point of view, every word has a different meaning. Strong is the opposite of weak. Means he maintains its structure under physiological stresses for a long time. This is a strong material. I can say this material is strong when I'm applying normal forces on it, and it's maintaining its structure under the normal forces. If it's weak material, when I put normal stresses on it, it gets fractured or get distracted or get damaged. What about stiff? Stiff is the opposite of malleable or pliable. So stiff is coming from the old stress strain curve. So stiffness is the area under the curve. The more the material is elastic plastic, this means that the more the material is has a plasticity, or the material is pliable. The less the material have after the elastic phase, the less plasticity phase, is more of a stiff material. And ceramic is one of the stiffest material we know on this earth. Third word is hard. And hard is the opposite of soft. Means it is very scratch resistance. You walk all the day, you drop objects, you put your chairs, you run, you jump over the ceramic, and it doesn't get notched, doesn't get scratched, doesn't get damaged or fractured until very late. So ceramic is a strong material, is a stiff material, is a hard material, and I hope the three words is the difference between the three words is clear to you. The second advantage is it's biocompatible, so it doesn't initiate any immunological reaction. It's bioinert, it doesn't induce any biological reaction, it doesn't cause metallosis or infection or immune reaction. It has a very smooth surface, and because of the smooth surface, we go back to the lubrication. It allows a fluid film lubrication. There is much less asperities in the ceramic surface, so the fluid film lubrication gives a better lubrication, less friction torque, more longevity of the stem. Last one is it is wear resistant, and we know that the ceramic, one of the most wear resistant material we use in orthopedics. And this is the main advantage of using ceramic material. Last one is the high wettability. And to understand the wettability, you need to understand that the surfaces in their reaction to the fluid, either it is a hydrophilic or a hydrophobic. Hydrophilic means it easily adapts to the fluid, and this ends by a very acute angle, contact angle. Hydrophobic means it refuses the reaction with the fluid, and this ends by an obtuse contact angle, and this is the character of low wettability surface. What's the add for this from this to us? If the surface is hydrophilic, means it's high, has a high wettability, means it's high, it has a good reaction with the lubrication fluid, means it's more prone to have a fluid film lubrication. While a low wettability means the surface is hydrophobic, so it doesn't react good, this doesn't goodly react with the material, or with the fluid, I'm sorry. So it has a low wettability, so it will not have a fluid film lubrication. So the high wettability of the ceramic gives it the chance to have a fluid film lubrication, means a lower friction, a lower torque, and a more longevity. Hopefully this is clear. What's the disadvantage? So if it's very, very nice, it's very, very advantageous like that, why we don't use ceramic all the time? No, we cannot use ceramic all the time because of the disadvantage. Number one, and the actual one, is very costly. So if you compare a ceramic to ceramic and ceramic hip to a metal and poly hip, it's about 3 to 4 times the difference of cost. So it is costly. Number two, it is susceptible to abrasive wear. Yeah, it is resistant, it's still very resistant to wear, but it has abrasive wear. Basically, if you go to the ceramic in your floors now and you abrase it with a sharp object, you will have some abrasion in there. Number two, it has a risk of edge loading, which will end by squeaking, which we'll speak about now. We agreed edge loading. If for any reason you missed to have the proper inclination of your cup will be open, means there will be edge loading over the cup, and the ceramic doesn't adapt that, doesn't easily accommodate that. End by edge loading, this increased risk of dislocation. This is causing what we call the squeaking, or the very noisy sound coming from ceramic and ceramic bearing. The other thing, because it is very stiff, yeah, it adapts a lot of stress before it fails, but when it fails dramatically. So your ceramic flooring will adapt your boys, your kids playing, running, falling objects, jumping from a chair on it, but the time it fails or fracture, it goes into pieces. So it is at risk of fracture. They try to reduce this now with a lot of modification in the way of manufacture, and the new, or the type 4, or the fourth generation of ceramic, which is the aluminum ceramics, has come across with good resistance to fracture. It needs definitely very careful handling during surgery, because as I explained to you, it's very stiff. So if it has any trauma or any injury or anything, it will easily fracture. Squeaking, and as we agreed, this is mostly because of one of two reasons. Squeaking is you hear sound of the ceramic moving on a ceramic when patient with ceramic on ceramic total hip walking. People think that this is just a sound. No, it's not just a sound. It is giving you an idea, either there is a third party, there is a foreign body inside the joint between ceramic and ceramic, or your ceramic and ceramic total hip is edge loading. So squeaking is not just a simple abnormal or noisy sound coming from a ceramic and ceramic hip, but it is a risk factor for this ceramic and ceramic going to dislocate. Okay, what about metal on metal? Why, if we know using ceramic is costly, why not to use metal on metal? Again, it has its own benefits and risks. It has its own advantage and disadvantage. So what's the advantage of metal on metal? Again, it's very strong as a ceramic. It's very stiff. It's very hard. And the good thing is more scratch resistant than your ceramic at some stage. Not every ceramic and not every metal. The other thing is has a very high conformity. So the two surfaces are very conform against each other. So as you see on this side, if you see the resurfacing, which is metal on metal, you see that the two surfaces are adapting each other in a very nice conformity. So that's why they have a very smooth movement. They still can be very nicely polished and manufactured with a smooth surface, so have some fluid film lubrication, especially as you can see with the conformity and the smoothness. Definitely it carries less risk of fracture than the ceramic, and the most important is very cheap in cost. Okay, what is the bad side of it? The bad side is, firstly, it's no wear resistance. It carries a risk of wear. And when we come to speak about wear in metal, we have to be very, very cautious. Why very cautious? Because metal gets a very large amount of wear particle, and they are very small. And this type of particles, of wear particles, which is a small and in large amount, induces the reaction or attract the reaction from lymphocytes, and this is ended by what is called alval or aseptic lymphocytes with vasculitis associated lesion. So the wear particles commonly in total hip replacement or commonly in arthroplasty surgery is the wear particles coming from metal and the wear particles coming from polyethylene. Difference between them, the polyethylene particles are low in volume or amount and bigger in size. The metal wear particles are smaller in size and large in amount. That's why the wear coming from the polyethylene particles attract the macrophage and get a macrophage induced reaction and end by osteolysis and wear, and we'll speak about that in a minute. And the particles coming from metal, which is smaller in size and large in amount or volume, induces a lymphocyte reaction and end by what's called alval lesion or aseptic lymphocytic vasculitis associated lesion. Okay, my metal on metal is nicely high conformity, have a fluid film lubrication, cost is okay, is very stiff, hard, and strong. Okay, the problem is if the wear from the metal on metal induced this alval reaction, you will have catastrophic problems. Problem number one, it induced metallosis, which again is a lymphocytic reaction against the amount of metal coming out from the metal on metal wear. Number two, this alval lesion in itself distracts the soft tissue around the hip, so end by your hip imbalanced and unstable. It distracts the ligaments, it distracts the muscle, distracts the tendons. So this end by the stability of your hip attacked. The metal particles in itself can induce a toxicity reaction, can cause a metallosis, can go and precipitate in different tissues in the body and cause a metallosis reaction. If you have a risky patient, like a lady in a childbearing period, a patient with renal transplant, a patient with impending renal failure, a patient with impending liver failure, you don't have the option to put a metal on him or her, because basically you cannot adapt the general reaction coming from the wear particles of metal on metal. Last thing is, even in an agreed patient who is, I need a metal on him because it's a large head, it's more conform, it's have a fluid film lubrication, like young people with very high activity, the metal on metal give them the best chance to have a good range of motion and to do a high impact activities, though they have a total hip. The cost of this, even the patient, I choose the patient not at risk. This patient has to have an annual surveillance every year. He has to come to the clinic. In your trust, if you do a metal on metal, you have to have a metal on metal clinic with a nurse, a specialized nurse, seeing this patient every year, firstly every 6 months, then after that every year, and taking doing a clinical assessment for them, getting a lab, assessing the amount of ions of metal ions inside the blood, ensuring they are not beyond the accepted level, and you have a very common guidelines in this about metal on metal bearing service. So yeah, strong, yeah, conform, yeah, fluid film lubrication, yes, give a good range of motion, yes, allow the patient to do a high impact activity, but it needs annual surveillance. It releases a lot of particles with a special character. They are small in size, large in volume, so they induce the lymphocytic reaction, do the alval lesion, which is aseptic lymphocytic lymphocyte vasculitis associated lesion, which distract the soft tissue around the hip. Any one of you who revised a metal on metal hip will never forget the picture of metallosis. Is darkest like a melena, is dark black, is dark black surface. All the tissues are distracted, and a picture you never like to see. Okay, So we moved from this because ceramic has its own problem and limitation, metal has its own problem and limitation, and we start from the time of Charnley to think about metal on poly or soft, hard on soft. This is now the gold standard. This is now have the best NGR results over the last 15 years or 20 years. So what's the advantage? Number one, using a poly insert, as you can see here, gives you a very good modularity. With metal on metal, with ceramic on ceramic, the modularity is very, very, very low. You don't have different sizes. You can play with the sizes. You cannot change the size of the head. You have to stick to a size because you have to match the size of the head with the size of the cup. But with metal on poly, you have the option to use different insert. So you have the option, they have the modular option to change size and play with it. It's definitely cheap. It's just a plastic. It's long life because as I explained to you, now the new modalities of the polyethylene, which is the high cross-linked polyethylene, is wear resistant, and that's why it lives long. Definitely it doesn't have any or minimally risk of fracture, has very good wear properties, especially the high cross-linked polyethylene is readily available everywhere. It's just a plastic. Okay, what's the bad or dark side of it? It's still causing wear, and the wear, as I explained you, releases a big particle but low in volume, and this is induce a macrophage reaction, and this is induce osteolysis and bone destruction. The wear particles of it can induce an immune reaction, and patient with metal on poly or hard on soft has to have a limited activity, has to have a low functional level, because metal on poly will not give him the full functional activity, or it will fail very early. So what affects the wear of the metal on poly? Number one, polyethylene itself. So the way you reduce your polyethylene, either by ram extrusion or compression molding, will end by you having a different types of polyethylene, which by consequence will have an effect on how much this polyethylene will wear. Sterilization, if you're using gamma sterilization, is different than if you're using material or using chemical sterilization. The thickness is definitely a difference. So if same idea of Charnley, if you're using a small thickness for a large head, you're jeopardizing the stability on behalf, the longevity on behalf of the stability. But the cutoff is 8 mm. Don't use a thickness less than 8 mm, because this will end by early failure of the total head. Though it gives you a bigger head, more stability, much better range of motion. Definitely femur head side, large head equal small plastic equal high wear, and the other way around. Process offset, if you we agreed, if you go to increase your offset, you will put a much soft tissue tension, and this will cause more friction and torque. If you decrease your offset, you're increasing the forces of the abductors, you're increasing your joint reaction force, and this will end by a higher wear. So you need to be in the middle, not a big offset, not a small offset, because big and a small offset, both of them will end by a wear of the polyethylene. Surface roughness is very important, and again, if you have a problem with your head, if you have a third party foreign body going in while you're doing your technique, this will be causing abrasive or a third party or foreign body wear, foreign body wear. And third party wear is very, very common, especially if you don't do a meticulous technique and wash nicely after you finish your total head. Again, I'll reinforce on the idea of wear at the end of the lecture. So again, definition is unintended loss of the material. It's either chemical or mechanical. We care about the mechanical. The common 3 types of wear mechanically is either adhesive, and as you can see here from the adhesive, is basically 2 surfaces against each other. One of these surfaces is more stiffer than the other, so it starts to get a layer off, and this is what we call adhesive wear. So harder surface than the other, like metal and poly, a lot of friction between them. What will happen? The hard surface will be taking a layer, adhere to a layer, and take it out and causing adhesive wear. Abrasive wear, as we agreed, it means something is cutting across the material, is losing a material by sharply cutting across it. Third party means there is another foreign body between both of them. The pattern of wear, either to be a liner wear, with this is happening commonly with a small head. With the small head, the head goes into the liner and causing wear into the liner into the poly in a liner way. So small head, if it starts to cause wear inside the body, it will be causing a liner wear. But if volumetric wear happen with a large head, so imagine a large head causing wear, it will be taking a whole volume from the body. So the pattern of the wear of the body, either to be a liner wear, means that the head is going in a line through the body, and this is called liner wear, and this happens with a small head. Volumetric wear means the head is taking a big part or a big wear part from the body, and this happens with the large head. The consequences we've spoken about, so synovitis, inducing an immunological reaction. Definitely, if it starts to, it has a specific pathway called the rank-rankle pathway, which get it to stimulate the osteoclast, causing aseptic osteolysis and loosening. If it goes to the systemic circulation, it causes systemic problems to the liver, spleen, and lymph node. Immunological reaction is definitely at a third party, increase the joint friction and misalignment, and it is biologically active, not like the ceramic, so induce the inflammatory and the osteolysis reaction. So what's the modes of wear? The common modes of wear is 1 or 4. If the wear happened as an intended wear, as an expected wear, or it happened between articulating surface or non-articulating surface. So in a simple way, every material we know, there is no material with no wear. Yeah, maybe very resistant, maybe the wear very rare and very and take a long time, but definitely every material, when you manufacture it, you know that this material will have some wear. This is type 1 or mode 1. Mode 1 of wear is the wear we're waiting for it to happen since we manufacture this material. Okay? Means in total hip replacement, if I do a proper total hip, I choose the proper patient, I do the proper technique, I have the proper alignment, I have the proper inclination, I have the proper version, I have the proper soft tissue tension, my total hip is perfect, perfect by definition. There will still some wear happening, but this wear I intendedly know that this will happen from the time I manufacture the material. This is called mode 1 wear. Mode 2 wear means it's expected. I know when I bought a metal against poly, some of the poly will be wearing more than if I bought poly against poly. And I know ceramic against ceramic, the wear will be less than metal than ceramic against poly. So this is mode 2, which is expected wear. What if I have a third party, which the articulation wasn't abnormal? I have a foreign body in between, a piece of bone, a piece of cement, a piece of metal. I will have mode 3 wear, which is the third party wear. Mode 4 wear is a wear when I have a movement between two unarticulating surfaces, like back of the insert and the cup. This no articulating, and this, I'm sorry, this no bearing, this articulating. So you have cup, fix it to the bone, insert, fix it to the cup, head moving inside the insert. If the wear happen between the head and the insert, this is expected wear. I know that this will end by somewhere. This is mode 2. If the wear happen between the insert, which is looking into the cup, so the wear happen between two non-bearing surface, this is what we'll call the mode 4 wear or the backside wear. So again, wears are 4 types. Type number 1, if I know from the time I manufacture the material that this material, any material in this world will have some wear by a degree, which is the intended wear. As you know, if you go for insurance company, you know that you'll not be paying for the wear and tear, because we all know there is no material without wear. This type of intended wear is mode 1 wear, which is intended. The type 2 is expected. I know that two articulating or bearing surfaces against each other will end by some wear, and this wear is higher in some bearing than the other. Like if we do metal on poly bearing, I know that this will be wearing more than ceramic on ceramic bearing or metal on metal wearing. So this is what is called expected wear. This is mode 2. Mode 3, if something comes between the two articulating surfaces, like a third body or a foreign body. Type 4, if this wear happen between non-bearing or non-articulating, something like back of the insert or back of the plastic and the cup. This is normally looked against each other. They are not articulating, they are not bearing surfaces. If the wear happen between them, like a backside wear of the poly, this is called mode 4 wear. So if the wear happen and induce osteolysis, how will I judge the osteolysis? How can we have a common language when you need to tell me that you see an X-ray of a stem or a cup with some osteolysis? We have to use the radiolucent zone, which is very common. Every one of you know. For the acetabulum, they are Charnley, which is one lateral, second middle, and third medial. And for the female, it's the ground zones, which is starting from the lateral in the EB X-ray, and starting from the front in the lateral X-ray. 1, 2, 3, 4, 5, 6, 7, as you can see, and you have to know this by heart, because this is the way of communication. If you want to tell me I have a patient with loose stem, you have to tell me where is the loosening, which radiolucent zone is there, because every zone of them has a different cause of loosening. Okay, so what about failure of total hip? How my total hip will fail, and we'll finish by this. So the modes of failure of total hip depend on how your implant is fixed. So the first one is pistoning, and pistoning basically means your stem is sinking inside the medulla. And this is two types, either the stem sinking inside the cement, or the stem and cement sinking inside the medulla. So pistoning means the stem is subsiding. If the stem is subsiding inside the cement, it's type A. If the stem and the cement is subsiding inside the medulla or the bone, this is type B. Second one, if I have my implant loose up and down, so loose proximal and distal, what will happen? This stem will mid-point pivot. So pivoting up or pivoting down. It's already fixed from the middle only. Up and down is already loose. So if your stem is completely loose, it will piston. It will sink inside the medulla or inside the cement. Either the stem sinking inside the cement, or stem and cement sinking inside the medulla. What if my stem is only fixed in the middle and it's loose up and down, loose proximal and distal? It will do a mid-stem pivot. What if my stem is fixed proximally and loose distal? This will cause what's called a calcar pivot. So it's pivoting up, it's holding up in the calcar, and pivoting down in at the tip. And the most common of them is the fatigue failure or cantilever, means my stem is fixed distal, but it's loose proximal. So as you can see here, after some time, it's loose proximal, and after some time, it will break because of the fatigue of the material. So again, how my total hip will fail? If my total hip will fail, it will fail by one of these four ways. Either the whole stem become loose, so it will sink inside the cement, or the stem and cement will sink inside the medulla, which we call pistoning. Number two, if my stem is just fixed in the midpoint and it's loose up and down, it will cause what we call mid-stem pivot. If my stem is fixed proximal and loose distal, this means it will pivot at the calcar, so called the calcar pivot, and this will end. This is very risky for a periprosthetic fracture at the tip. The last and the most common way, most common way of failure is the stem is well fixed distally and moving proximally. Firstly, will be causing a lot of osteolysis and a lot of proximal weakness and proximal bone loss, and ending by, after a lot of fatigue, after a lot of repeated cycles, it will be failing, material failure, and the stem will be broken. Okay, so we'll stop here before we go to biomechanics of the knee. I know it's a bit long. I'm sorry for the technical issue happening in the middle. It just the battery went and I didn't realize that the charger is not connected. I hope it is clear for you. It's I know it's a bit a heavy meal of biomechanics and principles, but I promise you this is the most important. If you understand the principle well, you will be applying them clinically well, and this will end by you doing a proper and evidence-based or understanding-based total hip replacement. This will end by your total hip replacement living longer, have a good stability, you have less revision rate, you're not an outlier on NGR. The whole lecture will be recorded. I will put it in the YouTube once we finish that. You will have a feedback after we finish this Zoom, and I hope you will be okay to fill it for me, so we know what's good, what's bad, what do you want me to improve in the next lecture. We'll run this course in 7 to 8 lectures according to the material we have. I'll try to make the lectures more concise. We're speaking today about the principles and biomechanics of hip and principles of total hip replacement. Next lecture, we speak about the principles of biomechanics of the knee and principles of total knee replacement. Then we'll go to speak about total hip replacement separately and total knee replacement separately. And we'll go a hint about, give a hint about the periprosthetic fracture and periprosthetic infection and what is the recent advances and the current concepts. Then we'll go to a quick lecture about shoulder and ankle replacement, which the third and fourth common after the hip and knee. Hopefully you will get most of it. I'm very thankful for your patience and your attendance and your careful listening. I'm ready to receive any question. If you have any question storming in your mind, put in the chat group and I will answer it. And if you don't have, I will be very grateful for you to, if you complete the feedback. And I will see you in a couple of weeks on a Friday at the same time. And hopefully you will complete this course in 7 or 8 lectures and will be useful for all of you. I'm waiting for your question if you have any, and thank you so much. We have a question about what is the older generation of ceramic head that looks radiolucent in X-ray? Is it all aluminum ceramic or something else? Abdullah, we will come to this in separately. I've just given you the principles, but we'll speak in details about the ceramic and types of ceramic and how ceramic comes, how ceramic manufactured and how ceramic sterilized and how this makes a difference between and what is the 4 generations of ceramic. So we'll speak about this when we come to it. There is none of them is completely radiolucent, but one of them, the generation was radiolucent than the others because the added material, which is just seal. When the fracture happened in the ceramic, they add materials and which seal the progression of the crack or the progression of the fracture, and this is what make the ongoing generations more and more radio-opaque rather than radiolucent. So I will explain this to you in details. We're just giving you today the broad lines and the principles. If anyone have any more questions, I'm more than happy to answer. Yeah, there will be a recording of the lecture. Once we finish that, I will put it on the YouTube channel. It's also Excel or Muhammad Hashim's educational channel, and it will be there. Sorry, guys, again for the technical issue happened in the middle, but I didn't realize that the charger is not connected. You're welcome, Sito. Okay, guys, if there's no questions, so we'll get this to a close. Thank you so much for your time. Thank you so much for attendance. Hopefully you will be okay to fill the feedback. Please feel free to fill feedback with all good and bad points. We aim to improve. We aim to offer you a proper service. So if you feel you need something else done, you need something shorten the time, increasing the time, another way of interaction, whatever you feel good or bad, please feel free to comment. It's completely anonymous. And if you want to add your email, so I can add you to the mailing list of also Excel, so I can send you all the events on time and get notified before anyone else. It's up to you. If you don't want, it's again up to you. But feedback is very important to me, so to improve the next sessions. Thank you so much, and have a very good evening and a good weekend. And see you in a couple of weeks on a Friday at 9 p.m. London time. Thank you, guys.